Okay. Welcome, everybody. My name is Nancy Merriman. I'm the Executive Director of the Alaska Primary Care Association and the Alaska Quality Improvement Network, or AQIN. AQIN is the name of the Alaska Health Center Controlled Network, or HCCN. So there's a lot of acronyms that we'll be tossing around tonight, and just stop us if we don't explain them. We want to make sure that this is useful to you guys, and it's not useful if we're using acronyms. So anyway, on the screen, the Alaska Quality Improvement Network, or AQIN. Let's see if this works. Yes. So this is our agenda for tonight. 3 hours sounds like a long time. We were going to move through this as quickly as we can, but making sure that we cover everything for you guys and that we answer all your questions. I'm going to take the next few minutes just to do a couple of introductions, but I'd love to know who you guys are and where your health centers are. So Colette, can we start with you and your group? Let us know who you are and where you are.
Hi, this is Dr. Sapp. I'm with Colette. I'm at Heritage Health Center in Powell, Wyoming.
Colette?
Right.
Okay, let's go here in the room. We'll start here in the room. All right, you guys.
This is Cole White. I'm the CEO of the Community Health Centers in Central Wyoming.
Awesome.
I don't know. I know I have to know, but I just don't know. I guess I just get that.
Okay.
You just don't know what.
Awesome.
Grace Tanzalara, and I am at the Wyoming Primary Care Association.
Right.
Quality Director.
Jean.
Hi, Jan Cartwright, Wyoming Primary Care Association.
Brenda Burnett, Wyoming Primary Care Association.
Yeah.
Kathy, Wyoming Primary Care Association.
Patty Landeska, Alaska Primary Care Association.
Colette, can you guys introduce yourselves?
Colette.
I think we're
Hey, Joy, can you hang on just a second? Sorry.
on the same.
I don't think so.
Colette?
Can you hear us?
Yeah, can you introduce yourselves?
I am just finishing. Sorry, I got pulled away for a sec. Dr. Sapp's going to introduce us, though.
Hi.
So is Dr. Sapp there?
Yeah. Did you hear us?
Did you say the doctor is going to introduce you?
Yes. I thought I was.
Hi, this is Dr. Sapp with Colette Mild, Heritage Health Center, Powell, Wyoming.
Awesome, thank you. So we're going to run through a brief introduction about the Alaska Quality Improvement Network and how the PCA figures into that, and then what opportunities might lay here for Wyoming health centers to join us in this network. So we are going to start with our mission, which is, oh, this is interesting. Right there.
Hi, this is Chris. Hi, can you hear me?
Yes.
Awesome.
Hey, Chris. It's Nancy. Hang on just for a second. Okay, I'm just going to run through just 2 slides or 3 slides about the Alaska Primary Care Association and AQIN.
Oh, sure. Yeah.
And then I'll hand it over to you.
All right.
Our mission, the PCA in Alaska is about 23 years old, and our mission is to create healthy communities by supporting vibrant and effective community health centers in Alaska. And your Wyoming PCA mission is similar in that it exists to connect the people of Wyoming with quality health care, every person, every need, and every neighborhood. This is just to show you how big Alaska is, but that we're not that different from your state. Our community health center system is made up of 27 community health centers that operate between 160 and 170 clinics statewide Each of those dots represents one clinic. They vary in size from like 1,500 square feet, serving less than 1,000 people, up to large multi-thousand square foot organizations that serve several thousand folks. Our largest community health center is in Anchorage and serves about 13 to 15,000 patients. I love this is your picture here with your Wyoming health centers.
Are many of them tribal? Run?
Yes. Goodness sake. There. Yes, we have 27, 14 are tribally affiliated, 13 are non-tribal. We have one faith-based organization and 2 public entities. So kind of an interesting mix, but yes, 14 tribal. And so they are dually funded both through, yep, exactly.
Are they 638s?
They're all 638s, yeah. So this is just a map to show you how far distant Alaska is from Wyoming. 1,400 miles difference, but is that right? 1,400 miles away, 2,800 miles, sorry, 49 hours away. But again, I think that distance is not that far when we think about how different or how alike our states are in culture and health systems and so many other things. Like when we think back when the ACA was being implemented, Alaska and Wyoming were often the 2 states together on the list as far as how our healthcare.gov systems were working and how many carriers folks had to choose from and how high the premiums were. So we find that we have a lot of commonality with you guys. So this, just a quick overview. Like I said, there's now 27 health CHC organizations in the States, about 170 sites, 14 are tribally affiliated. They serve over 113,000 patients a year. About 35% are Medicaid, 10% Medicare, and almost half are 100% below federal poverty. These are the same kinds of statistics for your Wyoming community health centers, which you know very well. We have very different Medicaid constituencies until you guys get your Medicaid expanded. Yes, in 2015, our governor unilaterally expanded it without the legislature. Yeah.
So with half being under that level of 35%, what's going on there? That 15% gap.
It's so we have a lot that are uninsured because of the high premiums, and then we have some folks. Some of the tribal folks are not covered, are not considered covered, because of IHS coverage is not considered like insurance coverage. So I'm going to stop on this slide, and Chris, I'm going to hand this over to you. So give me just a second while I switch it over. But our whole goal here is that we really wanted our health centers in the state of Alaska to be able to use their own data, to own their own data, to really drive their future and to be sustainable into the future. So Chris, I should have just switched over control to you. Are you able to maneuver?
Yeah, I think so. Let me go ahead and try this.
So I can see it on mine. I bet I need to take.
Oh, you might have to change. You have to change the,
Hang on, Chris. I can see your screen, but I cannot. It's not on the big screen.
right, so you have to change the monitor.
Oh, the monitor?
Yeah, you have to change.
So that it's up here.
Just like that.
You remember how you did this?
Yeah, except we lost activity. Chris, we lost the connection here.
Really? It shows me that I'm sharing, so I'm wondering, can nobody see, like,
It's our
Colette
cable.
could,
It's not you, it's the cable here in the hotel.
Oh.
There. Oh. Hang on.
There you go. Ah,
Oh, I think the help is help. Oh, it's
yeah, it's the
It's
HDMI.
the HDMI cable that's just having a hard time. Does it need to be hold it up somehow? Make that go away. Make this go away. Okay, Chris, we got it.
great. So who do we have from Wyoming, if you don't mind just letting me know who's on the phone that I'm going to speak to for the next short bit.
It's so funny. I just did that.
We have everybody.
We've
Okay.
we've got two health centers represented from Central Wyoming, and Colette, you guys on the phone are from where? Powell.
Okay. I apologize. I thought it started at 5. Did I show up a little late?
No, you're fine. We started a little early.
Okay. Well, no, I suppose that's helpful. So I'm just going to go ahead and get started here, provide you some overview and background and context before I jump into the demo. I'm going to try to keep it to about an hour and take a few questions before I have to hop off around 6:15 your time. So by all means, though, feel free to jump in and ask questions along the way, because I did build in a little bit of time for that. Just to introduce myself briefly, my name is Christopher Neal. I'm the Vice President of National Accounts. I've been working with Nancy and the Alaska folks for the past year and a half or so. It's been great getting the momentum behind their program and working with them as a team. You know, I have a couple of slides to get through again for some background and context. I will note this just because it's a slide that just came out through my CEO. We do have dates for our annual user conference where we have had folks from as far away as Alaska and Hawaii, even in the month of January when we had it, our first annual user conference back in 2017. I will be sending a copy of this deck as well for you to be able to peruse and take a look on your own time and come back with any questions that you may have. So to give you a little background on our company and where we came from, I've personally been with the technology since its inception in 2008. And it really came out of a consulting project that consisted of twofold success criteria. Now, the consulting project was in conjunction with the Mass League, which is the primary care association here in Massachusetts, where we're based, and 5 health centers that were members of the network that were looking to have more practical access to the data and being able to transform their data into a strategic asset. So the 2 success criteria of this project was to first and foremost be able to provide a BI, population health reporting and analytics solution for each of the participating centers, provide easy, more practical access to the data on a regular basis for all health center staff. Obviously, getting data out of your EHR and making heads or tails of it sometimes can be very challenging. So what we wanted to be able to do was to provide something different and significantly more comprehensive than what you can get from your EHR. And the second piece of success criteria was to build out a network platform or a common data platform that could enable participants within the network to collaborate with one another in a much more sustainable and systematic way. And so what we were able to do was to pull in the data that we were sourcing from the participating centers, EHRs and EPMs, and pull it into an aggregated centralized data warehouse where we could sort it and organize it, make sure it was apples to apples, and then uniformly apply measure specifications over that warehouse, such that all the health centers were not only able to look at and benchmark and collaborate based on their clinically integrated data, but we had formed a system that could evolve with the needs of community health. And so if you fast forward a few years, we had about a dozen centers representing users from 4 different types of EHRs. And that was when we really saw the applicability and value of this technology to community health nationwide. And Azara was formed to do just that. So with a laser focus on community health centers and the organizations that support them, we are now live at over 300 FQHCs. We have dozens of relationships with PCAs and networks around the country and in the 27 states that we're currently working with. Are there any questions on that background? Does that make sense?
No questions here.
Great. So,
Hang on,
yeah.
Chris.
Oh, sure.
Hey, Chris, this is Brenda. Hey,
Hi, Brenda.
do you work with any lookalikes?
Oh, yes, and lookalikes for sure. Yep.
Okay. All right, just making sure we don't leave anybody off.
Yep, several lookalikes, rural health centers as well, and yes, no, thank you for that clarification. And hi, nice to talk to you, Brenda. So, I mean, I saw the concept Nancy had on the slide earlier: own your data, own your future, help you easier navigate the challenges that are thrown at you from health and payment reform. And I think what is paramount to be to foster that navigation effectively is being able to have access to your data to be able to operate from that position of strength. So it's really important to wear multiple hats as I go through the demo environment and think about, data casts a wide web of value across different users within organizations and different types of organizations. So we'll just keep that in mind as I go through the various modules. I think what's also important here is to understand our vision. It certainly doesn't end at clinical integration. In fact, that's only the beginning. So, the foundation of how we work with all of the states that we put on board and the members that are participating in this centralized data program, the foundation of that is the clinical data from the EHR and EPM systems. But if you only look at that data and reporting based on that source data, you can miss out on other pieces of the puzzle or other data sources that could provide a more comprehensive view of the care delivery to your patient population. So what we've started to do to foster that piece is to integrate data from a variety of other types of data sources, including but not limited to ADT data, for example. So admit, discharge, and transfer data that you can use to have proper transitions of care and follow-up, identify your frequent flyers or your high utilizers, lower readmission rates, et cetera, et cetera. We can either do that by pulling data directly from a hospital. A lot of times it works well to source that data from an HIE that's collecting data from a variety of hospitals, but we can talk about a couple of different options for doing that when the time comes. Being able to push data to organizations is another critical aspect of providing value for the members that are participating in this. So, for example, in Indiana, they have a list of 15 measures that each and every center is responsible for delivering to the State Department of Health. Rather than each center be responsible for that on their own, we just built the center. We built the measures within Drives, and we already had 11 of them, but there were 4 additional measures that we went ahead and built out those custom Indiana measures and turned them on for everybody, so that the functionality of delivering that data to the State Department of Health no longer resides on center resources that are already constrained. It can now be done uniformly and very simply through the centralized organization. As we continue to go around the list here, certainly, as I mentioned, being able to participate in different types of public health initiatives, but last but not least, health plan data is something that we've made some major strides with over the past couple of years, where we can facilitate the integration of enrollment data first. That will enable the health center to identify their list of shadow panel patients, or those members that have been attributed to them who they've never provided care to, so that you can identify those members and be able to have proper and effective outreach and engagement. Following that phase, we can integrate care gaps data for reconciliation of HEDIS reports. We also integrate claims data for total medical expense and identifying your, who are my 10 costliest patients and how can we deliver that to our care coordinator and develop a plan around those patients. So things like that. So again, I don't want to overwhelm you. The foundation does come down to the clinical integration, which is what I'm going to spend most of the demonstration today showing you, but I did want to speak to our greater vision. I'm not going to spend too much time, if any, on case studies, because I do think that the most important thing is getting to some of the demo. But just so you know, within these slides, what you have is an example of where we've done this successfully before. We've been working with New York for several years, and really, at this point, we have 53 health centers live. We're getting enrollment data from 6 plans, care gaps and utilization from 5, and 3 HIEs that are integrated there. And I wouldn't be intimidated in any way by how far they've gotten. I think there's a sense of urgency now that enables us to get a whole lot further, a whole lot quicker with states that have joined us as recently as a couple months ago. We've been able to see some pretty enormous strides when it comes to the integration of different types of data sources, as well as encouraging the membership to get on very, very quickly when it comes to our implementation process. When it comes to the concepts that we bring to the table and our reputation in the marketplace, it really is that we meet the centers that we engage where they are, and we meet our clients where you are. And what that means is there are some folks that struggle with UDS. There are some folks that are looking to participate in an IPA and need the technical infrastructure around it. There's basically a whole spectrum of types of data usage that that our clients expect to adopt from us. And so what we need to know is we need to be able to identify your goals for data usage. We need to identify the measures that matter to you, that you want to or need to move the needle on, whether it's because you're involved in a program or there's incentives behind it. We really want to understand what those goals are. What's really helpful about working with a network and PCA like Alaska is they have the ability to bring folks together and align data usage at the member level with the data strategy and overall goals of the network. And I think that's really important to consider as you have your conversations amongst each other as PCAs and as the longer term approach for the network strategy. But what we do is we need to understand what at the center level the goals are and have that sort of facilitated through the program. And why that's so important is very much due to our implementation methodology. And this is really the last critical component that I want to speak to as a major differentiator of Azara Drives and what makes us successful at the aggregate level in terms of our implementation methodology. So this slide's really just going to kind of walk us through that. So assuming we've moved forward, making the decision as the network and get everything in place from a contracting perspective, we then engage each center individually in an implementation cycle. Connectivity, it can take between 2 and 4 weeks. It can take as little as a day. It kind of depends on which EHR you're on, but we have a couple of different approaches, and we work with 22 different types of EHRs. So there has yet to be an EHR that we can't connect with. I think RPMS was the only one that is it's an EHR that you can't query. So that became a roadblock, but the rest of them we're very well versed in, and we need to get that connectivity process taken care of so that we can access your data and start your implementation process. That consists of a pre-implementation meeting where we speak with members of your team regarding roles, responsibilities, timelines, expectations on the amount of staff resources that it will take to complete a successful implementation. And then we schedule your on-site kickoff. So the kickoff will come to visit you, spend a full day, and the main reason for this is to understand or get a better approach to your workflows within your EHR. So as I mentioned, it doesn't matter which EHR you use. What we concentrate on is how you use it. So there are a lot of reporting and analytics tools out there, including the reports that come out of your EHR, that will dictate where the providers need to enter the data into the EHR in order for the reports to be accurate and in order for the providers to get credit for the work that they do. We take a very opposite approach. We understand your workflows. We understand what custom fields you've built, what custom templates that you've built, in order to make sure that the providers are getting credit for the work that they're doing, regardless of where they're documenting. What we do insist is that it is reportable format. So there's no magic bullet, unfortunately, for free text or scanned documents, but it is, you know, for all other accounts and intents and purposes, our ability to go in and map your data so that the reports that are generated out of drives are accurate representations of the quality of care being delivered. Smoking cessation is always the best example when it comes to this, because there can be upwards of 30 places to enter that data element. And it's our responsibility during the implementation cycle to make sure that's mapped. So the next 6 weeks goes into our iterative review cycle of that mapping document, where we will work with whomever's most familiar at your at the center with the configuration of the EHR, getting the data into a really good workable format that we can then bring in some time from the providers to do data validation. Now, this is the other critical component. It's about 25 hours that we have dedicated during the entire implementation period, but a critical 25 hours that we have from providers to go through and do that data validation, which really has twofold, you know, importance. One, validated data is better data, and that's the only way that you can trust it at the network and within your organization or within the health center. And two, what we know in our experience, when providers participate in the setup of a technology, they have a much higher likelihood of enthusiasm and confidence in the accuracy and usability of the data post go live. We then come do a day of training on site, which basically sets up our next 8 to 10 weeks of adoption. So adoption is just sort of an extension of training and making sure that we understand what are your data usage goals, and making sure that we facilitate the proper working sessions once a week for that next 8 to 10 weeks, so that you really feel in a comfortable place of, you know, who's using the system, who has the proper access, how they're using it, having the system configured to meet their needs, et cetera, all takes place during the adoption phase. Any questions? I'll just pause and ask a quick question to Patty. I do have the slide regarding center resources that details it out that I sent to you. Are you going to take care of sharing that with everybody, or did you want me to speak to it at all here?
Yeah, why don't you speak to it quick, you know, just, yeah, I think it fits
Sure.
in better.
Okay. So this is the slide that I was just referring to. Basically, it's going to have all the health center roles listed out. Obviously, some of these roles can be overlapping. It also will list out each of the team member responsibilities, again, sort of overlapping between the center roles and who exactly is responsible for this. And it depends on the size of the center and resource availability for how you assign these roles and responsibilities. So we'll sort of work through this with you during that pre-implementation call to make sure that the time commitments are covered. Now, when you look at the time commitment column here, it's important to make sure that we communicate to you. We're talking about the number of hours across the 8 to 10 week implementation cycle. So when we say 4 hours, we're not saying 4 hours a week from an executive sponsor. That would be clearly unrealistic. But we do need that executive sponsor or executive champion to make sure that everyone understands why this is important, why the upfront implementation work will reap rewards as it pertains to the ongoing strategic asset of data going forward. So I have this in this set of slides that I can send that I'll make sure that you get after this, as well as I've sent it to Patty, and you can take a closer look. Let me know if you want to get on a call following this, or send over any questions via email regarding the expectations of the center resources. It's about 85 to 100 hours of work that we need in total over that 10-week process.
So Chris, I have included this in our slide deck, which everybody will get. And then Grace has a question.
Grace, this is Grace from the Wyoming Primary Care Association. Here in Wyoming, we have people who wear various hats. When you're looking for time commitment, do you add those hours? Say a person's taking 3 or 4 roles that are listed here.
Yeah, I mean, there's some economies when it comes to having one resource that's dedicated, but we work through all of those during that pre-implementation meeting to make sure that everybody's synced up. So I would say a little bit, but having that provider representative is going to be extremely important in having those hours carved out for that initial understanding of what's going on here, as well as that week 7 through 10, 8 hours for the ongoing data validation. That really needs to be taken care of by that provider representative. So I think that when you look through this, you can play with it a little bit and sort of let me know if you have any specific questions. But the idea here was so that you can go ahead and take a closer look on your own, see how it would apply to your unique staffing situation, and then come back with any questions so that we could tailor it to you as an individual organization.
So what percentage of health centers right now are participating in that? No, I mean nationwide. Azera has roughly 300, which works out about a 20% market share of all health centers. But how many? Because I was on the Alaska Primary Care. There's 10 of the.
We have 12.
12 now out of
27.
27. Yeah. So nearing a 50% adoption rate.
Yes. Yeah.
That's a good number, I think.
I think nationally, I think the number is above 50%. I think I heard them say it's somewhere between 50 and 70%. Did you hear that, Chris?
50 and 70% for what? I'm sorry.
For the number of health centers nationwide that are involved in networks.
Oh, that are involved in networks. Yeah, that sounds correct.
And so my only question would be, that level of participation, but then I wonder what the level of utilization is, because I remember one of my hospitals, we jumped into a similar situation and we signed a contract for sharing data, but boy, I think it took us maybe two or 3 years to begin really saying, wait a second, we're getting good data in and getting good information out from an operations standpoint that allows us to meaningfully utilize what we were doing.
So I'll share a quick story here about Bethel Family Clinic in Alaska. They onboarded they finished their onboarding in January.
Phase 1?
Nope.
Okay.
Just small.
It's just the name.
Sounds like it, doesn't it, Bethel?
Yeah, that's the name of the community. So they ran their UDS out of their EHR, which I think is next time. And they're looking at, they didn't think the data was very good. So they had just onboarded on to Azara, which pulls the data out of their EHR every night. And they'd been doing their data validation. So they were able to do that year's UDS out of using the Azara data. They have that much faith in it to be being correct because of all the implementation processes that they went through.
But the big thing, how you customize those reports and then compare it with how your peer groups are
Yes.
doing. So does the data only come from Alaska health centers, or is it across all? You expand that down and see how I am against all the health centers that are doing 30,000 visits a year, or only offering this? Can you drill down and say I want to put a very discrete cohort so that whatever I'm comparing my data against, it's against other health centers that look and smell and taste like that?
Yeah, that Chris, you can answer that one from a technical perspective.
Yeah, so we facilitate collaboration amongst all of our networks across the country. So if, for example, Wisconsin, we have a Midwest collaborative. So it's 5-6 states in the Midwest, Michigan, Wisconsin, Indiana, Missouri, Colorado, and I think West Virginia is actually going to join that. The idea being we are a common data platform for everybody nationwide, which means everyone's looking at their data from the exact same lens. We build the platform out universally, so the folks in Massachusetts are looking at UDS from the same lens as, you know, Hawaii and Alaska for that matter. And that's why HRSA really, really likes how we've laid out the foundation of our technology infrastructure. So when you log in, it's not like you'd see, here's Wyoming, here's Alaska, here's Hawaii, here's Massachusetts, et cetera, et cetera. We are designing that to be built out in the next year or so, where as soon as we get permission from specific, you know, network clients of ours, we can go ahead and show that high level de-identified benchmarking. Currently today, we would sort of have to facilitate that in a manual way where we get permission from everybody, and then we can sort of just send you the reports directly that you're looking for. But the concept of what you're speaking to is absolutely 100% by the philosophy of what we're trying to do and facilitate. But initially, what we're doing is network by network. So you would be able to see everyone in Wyoming and Alaska if this is something that you're choosing to do together. And then we could just expand from there. But the facilitation is with, you know, dozens of networks across the country.
And again, you said that the timeline before you have a nationwide integration of that data, so that when we draw it down, 3 years?
Oh, no, it's integrated. It's already there. I'm just talking about the user interface functionality where, you know, you log in and see how Florida's doing. From an aggregate, it's more. To be honest, it's just more from a data governance perspective. You know,
on the hospital side, we could go in and we could say, I want to see. This is my group of identified 15 critical access hospitals that have X number of services with X number of budgets with X number of volumes with a certain X number of people. We could literally start filtering it, because in our particular one there was like 400 critical access hospitals. We could say whether we wanted to look at groups that had hydro-based rural health clinics versus freestanding rural health clinics and things like that. So then when I'm comparing my information as far as how I'm operating, how I'm doing, I can really look at a very discrete cohort. And so you have these filters that allow you to have access to a lot more data rather than pulling something across in a report that comes out, you know, quarterly or monthly. Those are always retrospective. They don't allow for inter-period comparison. But you guys are looking at that.
Yeah, I mean, I think when I get into the demo, it may help you understand a little bit more clearly, in the sense that, you know, what this is it's clinically integrated data from all members of the network that can help you facilitate programs behind quality improvement, collaboration, responding to grant opportunities, leveraging hospital data where you can identify high utilizers and transitions of care, bringing in payer data so that you can collectively and scalably look at the care gaps and HEDIS measures, looking at your enrollment data so you can identify who's been attributed to you but you're not currently seeing. So it's a little bit different than the way you just sort of explained it. So I want to, you know, I think it might be, you know, helpful to start diving into the demo a little bit to give you a clear perspective of what exactly is in the wheelhouse.
Chris, this is great, but right now you can't provide that detail of apple-to-apple comparison, but you can provide statewide, right? Like all our centers join the network, they can compare each other, at least within the state of Wyoming.
Daily.
Or in Alaska, because it's part of their network, so that they're 12.
Yeah, I mean, and again, we can do it nationwide. We can facilitate that conversation by producing the data. The data's there, the reports are there, but from a data governance perspective, there isn't a program out there yet that says we have permission from all the participants in state 1 to aggregate their data and let state 2 see it. People are very much still in the stage of how can we make sure that we've maximized what we can do within our networks so that we can standardize the quality of care, run PDSA cycles, get all of the members on the same side and to the same level of understanding that this is all very important to engage in. There's a lot of work to be done on that level before you start extending outside of the state. But that's just me speaking from, you know, our experience. If it's something that you're ready to do and talk about from day one, we do have other folks at the table, and I think you're already there when it comes to speaking with Alaska and starting to explore what's scalable about their program. That's off to, you know, a fantastic start in the first year and a half. So, but I think, you know, if I dive into the demo a little bit, hopefully it'll help you to get a clearer picture of what we're all talking about. So, so I'm going to first start off by saying, and I think everybody's familiar with this concept of garbage in, garbage out, and maintaining the quality of data. And from our perspective, it's making sure that the data is visited regularly. And so what we've built in are tools within Drives to make sure that the data is visited on a daily basis, so that as workflows change, as you may have any changes to your EHR, everyone's on board with keeping up and maintaining that high level of data integrity. And the way we've facilitated that is mainly through a report that is by far the most popular report by end users at the center level, right? So this isn't, you know, an aggregate network view. I'm talking about a center level approach, is our patient visit planning report, or our morning huddle, which provides all the care gaps on the patients that are coming in for the day. So I'm going to go ahead and show you that first, and then we'll get into some of the aggregate level and drill down type functionality. But I first want to start off with this very important piece of functionality. So what this is showing is providers and the number of scheduled appointments that that provider has for the day. And I can click on this provider. We're in Dr. Black, and it's pulling up this patient visit planning report, or this huddle report. Okay, so I'll stop on this one, and mainly it's for identifying bottlenecks for the shift. It's for delegating various tasks to the MAs or LPNs so that the provider can spend the most amount of time with the patient, closing all those opportunities so that you can directly move the needle on measures that matter to you, whether it be UDS, meaningful use, HEDIS, patient-centered medical home, et cetera, et cetera. There's over 400 measures that are available in the system. So you're seeing the time, the day, and the visit reason, so data from the EPM as well as the EHR. Name, medical record number, date of birth, sex at birth, some SOGI elements, phone number, preferred language, risk stratification, last well visit, portal access, cohorts, which is a very important piece of functionality because you can put a subset of your patients and form a cohort that you can filter on for any of the measures in the system. PCP, payer, and care manager called out here. On the left-hand side of this slide, we're seeing the diagnoses, the risk factors, severe mental illness and psychosis. You can see substance abuse and dependency. If it's a female who happens to be pregnant, although not technically a risk factor, that'll be listed here as well. Social determinants of health. If you're using the Prepare module, NACS Prepare module within the EHR, we have a Prepare registry and we can map to that. If not, however, you're currently capturing social determinants of health in your EHR, we'll go ahead and make sure that that appropriately shows up here. Now, here's where the good stuff is in terms of the care gaps or opportunities that you have to close for today's visit on a per patient basis. The messages, what's missing, what's overdue, the most recent date, and the most recent result. This is very customizable on a center level. So when I said earlier we meet the centers where they are, one of the key pieces to that are what are the measures that matter to you? And in doing so, we identify the alerts that should be turned on versus the alerts that can be turned off. Because what makes this truly unique within this technology is all of these alerts that you're seeing here are tied directly to the underlying measure logic. So as you're closing these care gaps in the EHR, it's directly impacting those measures that you're focusing on. As far as the messaging, for overdue, we can tailor those parameters to your specifications. If you want to tighten national guidelines, we can go ahead and do that for you. And then we have open referrals without a result. So we have a referral management reporting module. One element of that reporting module is to show open referrals without a result on the patient visit planning report. The other thing that you can do with risk stratification is to add that as a filter within the patient visit planning report. So if you want to go ahead and have your care coordinators filter the daily huddle by your high-risk patients, they can go ahead and do that. Medical record numbers I can type in for walk-ins that surprise you for the day. We'll regenerate this report with data from those walk-ins. If you want a more clear picture of the patient care longitudinally, I can click on the patient here, and it's not only going to show you the items on the patient visit planning report, but it's also going to give you a care summary of that patient over time in a care management passport. So now you're seeing last 10 assessments, last 10 problems, codes, descriptions, and dates. Care delivery, the numbers over time for up to 5 observations for BMI, systolic, diastolic, LDL, A1C, PHQ-9, and risk. We have social determinants of health here, alerts, medications, open referrals without a result. And if we are collecting transitions of care data, you'll see the IP and ED utilizations down here. So this is a more comprehensive summary on a given patient, but these are the 2 patient-centric reports that really foster that level of confidence in the aggregated data, in the accuracy of that aggregated data, because it's so useful at the patient level. Are there any questions on the 2 of these before I move more into the population and network view? Okay. So from here, I'm going to go into the measure analyzer. And so what this is doing is basically it's going to enable me to drill down on a measure. Now, there's lots of reports in the system. Here are all of your UDS tables with the clinical data from the EHR and PM. So 2018 CQMs, the ever so popular patients by zip code, care gaps, which is going to show you the exact CQM related gaps on a per patient basis, tables 3A, 3B, 4, 5, 6A, 6B, and 7. Obviously, very popular this time of year as folks approach UDS season and want to understand how they can more easily do that and run UDS more regularly throughout the year to be able to drive quality improvement. But what I'm going to do is just show you a subset of measures that I have on my homepage that happen to relate to adult diabetes. So you can set whatever set of measures you want on your homepage that matter to you at the network level or within an individual health center. And I can click on any of these measures to dive into this the way I'm about to in a minute or two. But I'm going to click on the full report first. So this is a network view where we're looking at 3 fictitious health centers that are participating within this network. And we're seeing that aggregated data for how they're performing as a total result. So 84.3% based on the numerator and the denominator and any exclusions. It's a very user-friendly system. It's not an IT system. It's a clinical system. So we need to have everyone understanding what it is that you're looking at in the form of measure documentation, the definition of the numerator, definition of the denominator, link to technical specifications if you do have questions, or other additional links to other resources as well. I can go ahead and filter on any of these. So if I'm a single center, I can say, all right, I'm in Access Community Health, and I want to go ahead and see how I'm doing against a baseline period. So right now we're looking at trailing year, September 2018. If I want to say, I want to know how much better or worse I'm doing in September 2018 than I was in June, for example, I can go over here and let's say June 2018 as a baseline period. I can update this report, and within my center, it's going to tell me exactly how my percentage has changed in terms of performance, up, down, or even, for all of these measures that matter. And I can bring this up to the network level, where if I eliminate that filter, I can update this, and now it's showing how I'm doing across an entire network, where I'm saying, hey, as a network, we're trying to get to this target, 56.5, and I want to know our improvement or decrease or staying the same on these measures with all the folks that are involved in my quality committee. So I'm going to just go ahead and show another example crosstab that tends to be pretty helpful. And let's see, I'll do
Hey, Chris.
grouping. Yes.
I was just wondering if there's a way to make the screen or to make the words on the within Drives a little bit bigger.
Now, that wouldn't be from me. If you have a screen that is I mean, my screen's rendering properly. If you have a, I don't know, a way to blow it up in a projector or something like that.
Yeah, we're gonna try. We're gonna try it. So it's a little bit small, but go ahead, keep going.
Okay.
So Chris, while we're talking to you, this is Patty. At some point, they just had UDS training today. At some point, could you show them the functionality of the UDS reports?
Yeah, sure. I'll go into that right after the drill down here.
Thank you.
So I'm going to go into a scorecard format. Let's see. And we'll do centers. Okay, hang on 1 second. Okay, so what we can do here for a crosstab format, I'm going to go ahead and put centers as the crosstab. And so what this is doing is there's those 3 centers that I mentioned are in the demo environment. So these would be, it would be more busy in Alaska, and more busy the more, centers that you get up and participating. So these are the 3 centers that are participating in this demo environment. And here are my measures from the home page. So if you wanted these to be, UDS CQMs, you could go ahead and have that happen. I'm going to show you that in a moment. But here's the performance by center within the current period. I think, if we want to take a deeper dive and go to locations, we can look at locations performance across one another. And the performance in the current period, you can change the period type to monthly, quarterly, trailing year, or year to date. If I want to go down to the provider level,
Hey,
within
Chris,
a thing, yes.
can I have you just hold on? I just wanted to make sure that April and Crystal in the room here were seeing that, because they have multiple locations. I just wanted them to be able to see that they can indeed look at their patients by location.
Yeah, and I'm going to be able to show that within the measure analyzer too, but here's the ability for you to, for whatever set of measures that you want to focus on. Like I said, this is just a subset for me, but you'd be able to see the performance of each of your locations within the current period. You also could see the performance of each of your providers in the current period. So for things like meaningful use, where there are very specific thresholds per provider, this is really helpful as well to identify those areas of opportunity for improvement. So I'm going to go back up and we'll do dive down in a single center, or sorry, a single measure. So I'm going to click on diabetes eye exam, and we're going to just sort of explore how you can look at a single measure and trend over time, and filtering in a whole variety of different, very flexible ways to get to the data that you may be interested in. So we're looking at period type, trailing year again, from trailing year September 2018. We have the 3 centers that are involved in this. We're looking at the primary and secondary targets represented by the green and the orange lines here. The trend line over time from 78% to 84%. And as I scroll down, we're seeing the center's performance amongst one another. So we have Family Health Center, Access Community Health, and Neighborhood Health Center. Now, just to be very, very clear, Access Community Health cannot dive into Family Health data. Only if I'm a staff member of Family Health Center and have the credentials to do so, can I click on it, and it's now going to filter me and my performance for just my health center for Family Health. So we're seeing it go from 80% to 86%. Now, if I'm in Family Health Center, I can also look at this report by rendering provider or usual provider. So depending upon the level of open access, that can have an impact. I can ad hoc group providers together, or I can, hard code, so to speak, make a provider group or groups available within here. And if I say, all right, here's 86%, I want to know about the other 14. I want a patient list around that. I can click detail list, and it's going to immediately pop up my patients that are not in the numerator, or it will at least enable me to filter or sort by the numerator so I can understand which of my patients are eligible for the diabetes eye exam within the current period or within the qualifying period who have not had their eye exam. So as I scroll over, we're seeing eye exam date, diagnosis code, and diagnosis date. I can see that this particular patient is not in the numerator. If I say I want to know why Diana is not in the numerator for investigative purposes or to do ongoing data validation, if you want to understand why it is that specific patients are not included in the numerator, I can investigate the measure, and it's going to show me the exact criteria that that patient did not meet in order to qualify for the numerator of this particular measure. Again, keep in mind this functionality is applied across all the hundreds of measures in the system. So that one said that the eye exam didn't take place within the qualifying period. Now we're seeing a patient that did not have an eye exam. So if I go ahead and investigate the measure here, we're seeing that the eye exam never took place. There's not an eye exam recorded. So it gives you the specificity of at that level of exactly why the patient is not included in the numerator. I'm going to go back up to Measure Analyzer, and for the folks in the room interested in grouping by location or discrepancies by location, here you have it. So you can see Lakeview Adult Medicine, First Street Clinic, and Florence Ave Center. These are locations within the health center that I drilled into. If I want to look at secondary groupings for discrepancies based on really any of these items, I can go ahead and do so. So if I want to look at discrepancies by housing situation, I can go ahead and do that. And it makes this nice little chart here from unknown, homeless shelter, street, not homeless, doubling up, or transitional. If I want to do something by, sex at birth, I can go ahead and do that for any of the measures as well. So just a little opportunity for some primary and secondary grouping to find some more interesting charts that you want to dig into. Now, at this level, you could have reasons for the centers or the locations to the right. I'm sorry. It could be rogue workflows developing. It could be a training issue. It could be legitimate workflows evolving that we need to go back in and map. All of these legitimate, but this is offering you the opportunity to allocate some resources, take a deeper dive of what's going on behind the numbers. So I'm going to go ahead and click on Lakeview Adult Medicine. And it's at this point where we're looking at the location's performance over time. And I still have the detail list that I can click into. I can save any of these reports to my homepage. I can pull the underlying patient level detail into Excel. I can save this as a PDF for a PowerPoint presentation. But as I scroll down, we're seeing the provider's performance amongst one another. We'll often see providers at 100%, but if the denominator is 1 or 2, that's not all that helpful. So we do have this table view where you can see the providers, the performance, the numerator and the denominator, and you can sort on the denominator to sort of identify that low-hanging fruit. So we can see Dr. Plant here at 67%. I can click on Dr. Plant, and it's going to show me that trend line over time, which is quite volatile when it comes down to the single provider. But you can see any interventions that have occurred, any demonstrable results of PDSA cycles over time by looking at these trend lines over time. The logical next step may be the detail list behind this for patients that have been assigned to Dr. Plant that are diabetic. I can go ahead and add a comorbidity if you like. I can add, housing situation, race, ethnicity, social determinants of health, a cohort that may be unique to my health center, plans, payer groups, financial class. A lot of opportunities here, but I'm going to click on patient diagnosis so I can show you the example of a comorbidity. So I can click on hypertension here, and it's going to add hypertension as a filter. And what we're looking at is 2 pages of 15 items or 15 records within this report. And we've drilled down on diabetes eye exam all the way down to the granular level of one provider whose patients have been diagnosed with diabetes and have not had their eye exam within the qualifying period, who have also been diagnosed with hypertension. It's a fairly sophisticated level of detail here, but in a very user-friendly way, right? Like I could give this mouse to anyone in the room, and maybe you wouldn't repeat that workflow exactly click for click, but you'd be able to intuitively navigate the system. And that's why it goes back to my comment earlier about it being a clinical project and not an IT one. You'd mentioned the UDS report, so I'm just going to show you an example, the care gaps that we came up with this year, which has been really, really well received when it comes to the CQMs that are included in or required of UDS. So again, if we're at My Center, so we'll look at Access Community Health. Give it a moment to load here. We're seeing the patient name and MRN, and we're seeing the care gap for each of the patients. And then we can see which of the measures that the care gap applies to. So if we're looking at Lewis here, we're seeing there's a care gap around BMI screening and follow-up, IVD aspirin use, and A1C greater than 9 or untested. So, so that's really helpful all the way down to the granular level of, this is around closing those gaps and really using UDS to drive improvement across your organization. And that's just at the granular level, right? So if we wanted to do, I like showing table 3B. This goes down to what I mentioned earlier about the evolution of the system as requirements change for you over time. So last year, when they instituted the SOGI requirements, what we were able to do is to pull in our network clients across the country to pull together for the development of these of this element on table 3B, and build it into our user interface here. And then we went and sourced all of this data from the EHRs that we were sourcing data from across the country so that we could produce these reports without bothering a single center resource. And that's the power of what we're trying to do as it relates to concentrating specifically on the needs of community health and our network clients that support the health centers. The rest of them, tables 3A, 3B, 4, 5, 6A, 6B, and 7. If I click on 6B, it's essentially going to be that list similar to what I showed you earlier. However, you can always get to the patient level details behind. You can always, just see what we, probably similar to what you'd expect from a UDS report, but just giving you those granular patient level details for ongoing data validation and making that easier for you to do. I want to go up to dashboards and show you an example of like a diabetes dashboard as well. There's a lot of different graphical representations that you can use to build your own custom dashboards and scorecards. A lot of places will go ahead and foster that collaboration, or call it what you will, collaboration or competition, and have provider performance put up in staff rooms and forming incentive programs around them, things like that. There's a lot of options here. I'm just going to show you a few dashboards that you can sort of pick and choose what may or may not be applicable to you. Sticking with the theme of diabetes, we're seeing just a count. So if you as an organization say, I want to know who my diabetic patients are, or I want to know the count, I want to know the number of my patients that have been diagnosed with diabetes. Here's an example. And you can do that with any of the chronic conditions. I just have diabetes built out. A1C greater than 9 or untested over time. Control diabetics, A1C less than 7, I'm performing at 28%. Let's say I want to go ahead and take a look at how I'm performing over time, or I want to take a deeper dive because I'm really not hitting my numbers. I'm not even hitting my secondary target. I can click on the measure here, and it's going to bring me directly to the measure analyzer that I rolled us through when it came to diabetes eye exam. So very intuitive to navigate around different parts of the system. Continuing with this dashboard, we've grouped by A1C results, so less than 7, between 7 and 8, between 8 and 9, greater than 9, and patients with no A1C. We are certified on meaningful use CQM, so we have the scorecard here for you. We're also pre-validated for PCMH. You also have uncontrolled diabetics by age. Cancer screening is what had facilitated a $14 million grant in New York for the implementation of those 53 centers that I showed earlier. We're seeing breast, cervical, and colorectal cancer screening, which is what the CDC was looking for related to that grant. And so we have it within the current period, we have it trended over time, and we have those screenings by location. This has been really powerful for a couple of programs that we've run with not only the CDC, but American Cancer Society and LSU in the form of specifically concentrated on colorectal cancer screening. I wanted to share that with you as well. The referral management module that I mentioned before is a really valuable extension of the system that the Alaska Primary Care Association has invested in. So I mentioned earlier the open referrals without a result for each of the patients that are coming in for the day. This is that more aggregated view, so you can see how you're performing as an entire organization. So I'm looking at my percentage of referrals across various stages of the life cycle, from open, completed, canceled, deleted. If I'm at open referrals at 63%, my primary target is my secondary target is 43, my primary is 33. I can click on this, and it's going to now bring me to my count over time of referrals. And if I'm so inclined to see those referral line level details, I can click the detail list, and it's going to draw up those referrals at the most granular level, so you can see the patient name, the MRN, the referral type, referring provider and location, to provider and to location, and all sorts of columns down here from responsible party, primary payer, referral priority, ordered, scheduled, appointment, received, completed, canceled, and deleted. Now, I do want to continue down that dashboard a little bit further, because then you have your stat referrals open greater than 7 days, your urgent referrals open greater than 14 days.
Hey, Chris.
And anytime, yes.
Chris, this is Kathy at the Primary Care Association. We're having some trouble with the audio visual. Can you give us just a minute to see if we can switch out a cord and fix it?
Sure.
Perfect. Thank you.
It hasn't been affected, or just been on in the room here. People haven't been able to see sometimes.
Okay.
Just have to move it back.
Okay.
Just a little bit too small.
So can you go back any further? All right, Chris, we're ready. Thank you.
Yeah, you can see.
Thanks, guys.
Okay. So in case you couldn't see it, you could see now the odometers for the different stages of the referrals in the current period, from open, completed, canceled, and deleted, and being able to drill down to the referral line level detail. So getting to all the numbers behind this is the theme, right? Everything is as clickable as the next. So if I want to see my stat referrals open greater than 7 days, or my urgent referrals open greater than 14 days, this is very popular. If I want to see who my open referrals by provider, here's Dr. Barr with 274 open referrals. I can get right to that granular level of detail that I need. I would say about 70–75% of Azara Drives users nationwide have chosen to adopt the referral management module, just because it tends to be a constant juggling act that the health centers struggle with. So that's the referral management module. I think, in the last few minutes here before taking some questions, I did want to get to the part where I wanted to talk about the health plan enrollment integration as a phase 2. I think first and foremost, we need to get that foundation behind the clinical integration and the clinical data that I just demonstrated. But then when it comes to subsequent phases and that better, more comprehensive picture of how you can deliver quality care to the attributed members that come to you from the plan, we've decided to sort of expand our horizon into this type of functionality that I'm going to show you both here and in one additional report that we'll get into regarding HEDIS reconciliation, and then I'll take some questions. So what this report is showing is data from 3 fictitious health plans. So we're seeing Community Health Plan, United Health Plan, and Group Health. And so often you may get these files from the plan where you have to manually sift through to identify, who are the attributed members that I'm not currently seeing. And that can get very frustrating, especially since it's coming from multiple sources. What we want to do is have this all consolidated in one usable operational format that fits with your workflows. So the first thing that we do is go through enrollment matching. And so we have the number of attributed members here at 4,497. We take that attribution list and we match it against the patients that we're collecting data on out of your EHR. And we identify this list of unmatched members, or members that have been attributed or assigned to the CHC that the center is not currently providing care for. So they now have this list of members to actively outreach and engage. We've also stratified them by age because we found a higher likelihood of success within specific age ranges. Pediatrics, parents, not quite geriatrics, but where chronic diseases start to form. Avoiding certain age ranges that may avoid the doctor. Then we've also taken another step to say matched members by last encounter, because for the purpose of managed care, right? A lot of the managed care plans dictate you've seen the patient within the last year. So here are those that have come in to see you within the last 2+ years, but not within the last year. If you have any patient records that don't have a face-to-face encounter, maybe you got a file from an affiliated hospital and made records around a specific set of patients that were utilizers, but they never actually came in for a face-to-face, you have that list here. As I scroll down, we're seeing members that are active in the period, newly ineligible members, newly eligible members, matching trends. So if you see that matching trend line start to bend downward, you know what happened. We're a whole additional slew of patients, or I'm sorry, whole additional slew of members attributed or assigned to you that you were unaware of. And how can you form a strategy when that happens? And how can you, appropriately approach the table for discussion with the plan that assigned you those members? And then we have just your matched members. What's your match rate, right? We like to see between 60 and 90% in reality, and there could be a whole slew of reasons for that variance, but this is dummy data, so it's at 30%. But what is your match rate, right? What is the percentage of attributed members that you are providing care to? This is all really helpful stuff when it comes to reaching out to that list of shadow panel patients, or those members attributed to you who you're not currently seeing.
Chris?
Yes.
We had a question come in through the chat. So they would like to know if you could define the word member. Is that a member of a managed care organization or a patient that has been to the health center?
Yeah, so that's the point. That's the matching concept here. So when I say member, I mean a member that has been assigned or attributed from the plan or from the managed care organization. And we're matching that attribution list of members against the patients that you're actually seeing and delivering care to in the health center. And that what that enables us to do is help you identify those members that have been assigned to you that are not your patients. Nancy, I'm sorry, I don't know who asked the question, but can you verify that that answers the question?
Colette, was that helpful?
I'll sort of talk, well, hang on, it looks like are there more? Let me see, I have 2 chats. Oh, that was Kathy.
Oh.
Looks like.
Okay.
All right. And that applies to this next report too. So hopefully it continues to become increasingly clear. So with this care gap reconciliation report, we're taking the HEDIS measures, and Colette, thank you for that distinction, because there's two types of HEDIS measures that we provide out of drives. One is the what we'll call patient-based HEDIS report, and the other is the member-based HEDIS report, or the measure that's calculated by the plan. And what we're doing here with this reconciliation report is we're reconciling the data from the plan with what's captured in your EHR to help you close the gaps that are that need to be reconciled without delivering care to a patient, without using any provider time. So here are the measures, right? Here are our HEDIS measures, and I'll go ahead and click on colorectal cancer screening, and I'll update this report, and it's going to form a quadrant. So what this is saying, I'll just step us through it. Colorectal cancer screening, member-based, right? So this is the HEDIS specification for colorectal cancer screening, and the member list is 773. So from the plan, there's 773 members that have been assigned to you that are eligible for colorectal cancer screening. So now we've broken them out in the second tier here between matched and unmatched. So the unmatched members are members that have been assigned to you who you are not currently providing care to, so they are not your patients. Over here, we have our matched members, or those members that have been assigned to you who are your patients, right? So maybe here's the best part to, place to start with. We can see 131 of them have had visits in the last year. We see 112 of them who have not had visits in the last year. So then when we take a step below, we're seeing this red box here where both the payer file and the EHR agree that the procedure did not take place. So let's pretend, I'm sorry with the dummy data, let's pretend that this 0 is actually the number 10. What that 10 would represent are 10 members from the plan that are actually patients of yours, where both the payer and the EHR agree that the procedure did not take place. In the green box is where they both agree that the procedure did take place. So you're seeing 3 eligible members that are your patients that the systems both agree they have had the procedure for colorectal cancer screening. Now the orange boxes is where it gets really fascinating, because this is where you're seeing 109 here, which is where the plan has said there are 109 members that have been eligible for colorectal cancer screening, where the procedure has taken place and they've verified it, but the EHR says it did not take place. So by clicking on this list, it's going to pull up the patient details where you can go into those charts and update the charts to close that particular gap in care for colorectal cancer screening, or whichever one of the HEDIS measures that you're focusing on. And alternatively here, where we have this orange box, which again, unfortunately is 0, but let's say it's 10, is where you would have 10 of your patients that are members from the payer that the payer considers never to have received their colorectal cancer screening within the qualifying period. But in your EHR, you don't have that as a gap. You actually have the record of it occurring. So by producing the proper documentation and delivering that to the plan, they can update their data, and everyone can agree that this then can move into the green box. And we're talking about closing a significant percentage of care gaps administratively without using a provider time or without seeing a single patient. And that's really what we're concentrating on doing with the functionality of this report. So again, there's a little bit further down the road. It's subsequent to collecting and sorting and organizing and getting you used to using the clinic data from your EHR, the clinical data from your EHR. But it is certainly an exciting front that we are going down the path of to integrate more meaningful data for you as it relates to what's going on beyond what you're doing within the health center. So I have a couple minutes. I can take some questions, or Nancy, Patty, if you want to advise me to certain places that I can talk to for the next couple minutes, but I'll leave it up to you.
Hey, Chris, thank you. Let's see. I had one thing I Cole left. He wasn't able to stay, it looks like, but he had one comment at the beginning before he left that I thought was really important, and that was his concern that systems that he's seen that purport to do similar things as Azara drives often take a very lengthy amount of time before they really are valuable or useful. And so, Chris, I wanted to just pose that to you and see if you had comment.
Yeah, I mean, there's no doubt that programmatically things take time. But from a systems approach, this is fully built, fully functional. I have not shown anything that is vaporware. I think one of the questions that was asked of me at one of the dinner tables at the PCA conference was, describe a failed implementation. And we really have not had a failed implementation. It really comes down to, as long as we have the resources that we need from the staff level at the CHC, we do have the methodology in place for you to be up and using and successful with what I've demonstrated here, 8 weeks following the kickoff of the implementation. And from there, I'm not the person that you should rely on for that information. We have market reputation. There's hundreds of CHCs that can speak to what I've spoken to today. I think the Alaska PCA can speak to it with more credibility than I can, because I'm the vendor. I get it. But I am happy to say, and pleased and honored to say, that we have a lot of folks that you can turn to ask, how does this work out from a real world perspective? And I think that that's as best as I could sum it up. But well, Nancy, would you agree? Or
Yeah, definitely. I think that the stories we have heard from Alaska Health Centers that have gone through the implementation, the comments we've heard was the implementation is not as bad as it might look by that table. That looks like there are a lot of hours that go into it. There are hours that you want to invest on the front end to make sure that your data is getting mapped properly. But what we've heard back from health centers is it's definitely not as bad as they thought it was going to be. And then as soon as the switch gets flipped and you're live, you really are live, you can do all of the things that Chris just demonstrated, and that it's a very intuitive interface.
Yeah, I think Nancy, just to add one little point to that, is that it's not even that it's that bad, not that bad, but it's actually helpful to revisit some of your workflows within your EHR. So a lot of centers say that there's a lot of value in participating in that implementation to revisit the workflows, tweak some of the uniformity with which you're entering the data into the system. We will highlight any areas where there's data that's being entered in free text or non-reportable format, which everyone needs. Everyone needs to do and visit. So there's actually opportunity with that implementation as well.
Well said, Chris. And actually, thank you for saying that, because that is additionally what we have heard from folks, is that process has been extremely instructive for them. And as I guess we will say goodbye to you, I know that Cricket is on from Sunshine Community Health Center in Alaska, and she can help us to tell this story and to demonstrate what we have just said. Does anybody have any last questions for Chris?
I do. Can you hear me? This is Colette.
Yes,
Hi,
Colette, we can hear you.
Chris, we are on Athena, and Dr. Sapp and I are going through, and a lot of the data that you're providing, I see the integration benefit for the networks and that sort of thing. Can you actually give me an example of another Athena user that has, and what they benefit from that? Because I'm seeing a lot of redundancy in what we can already pull from our EHR, and as far as dashboards and that kind of stuff. Can you speak to an Athena user and what they got out of Azara that they weren't getting out of Athena?
Yeah, I mean, so we're actually MDP partners with Athena because they're not bringing to the FQHC marketplace the full comprehensive reporting and analytics solution that they've been talking about for the past couple of years. And so we're sort of coming in to be able to be the provider of that comprehensive solution. So like any other EHR, you can pull some things from Athena. It tends to be very cumbersome and complicated to get the data out and make proper heads or tails of it. We probably work with, at this point, 24 or so Athena clients, and I'd say it's probably just about matches the market share. So there's no one EHR that needs us more than another EHR, but we work with Athena users, both very, very large and very, very small. So 3 lower counties, or Chesapeake and Maryland, as well as implementation that we're doing right now for Fort Yukon up north of the Arctic Circle, one of Nancy's crew. So I would say that beyond that simple short explanation, might be helpful to talk to one of our Athena users.
Okay.
So, all right. Well, thank you, Nancy, Patty, everyone from Wyoming. Cricket, I'm sorry I can't stay on to hear your presentation, but I'm sure that you'll do a great job, and I look forward to any of the follow-ups that anyone requires of me to answer any questions following this presentation.
Excellent, Chris. Thank you so much. Have a good evening. We'll talk to you soon.
All right. Thanks, everybody. Bye-bye.
Bye. So Cricket, can you hear us?
Yes, I can hear you.
All right, excellent. Would you like to be the co-host on Zoom, or I don't know if you have any things that you'd like to share?
Yeah, can I get my screen shared?
Yeah, hang on. Okay, it should have happened. Do you have control?
Yes, sorry. It was just lagging for a moment.
Yeah, it does. It does.
I'm trying to find where I'm at.
Let me stop sharing mine and then.
Okay.
So you're going right to your drives.
Okay, I got to get this bar out of my way so I can get up here to my. How do you get this bar out of the way? At the top?
Oh, let's see.
Ah, I moved it.
Did you get it?
Yeah.
All right,
I needed to be able to get the path for my drive.
There you go.
I first off wanted to start out by our backstory and how we've had issues in the past with analytic programs or data platforms, warehouses. And I started out here quite a long time ago with Sunshine Clinic, and we're a small community health center in Talkeetna, Alaska. And for a long time, I actually drug all of our data out of chart auditing manually for a long, long time. And then we started getting these people trying to sell us things. And of course, we believed it and we bought them. So we went with this Viz Analytics program, and they said it did the world. Well, I thought it did the world until I started diving into it and investigating what it was doing. They did not sit with us the way that the Azara people did and actually validate our data with us. They turned a program on and said, you're good to go. And these were our UDS measures and everything we were trying to get out of this. Centricity is our EHR. It's hard to report a lot of things out of Centricity. You have to dig a lot. A lot of their reports aren't great unless you know how to build them. So we use the Viz Analytics system for, I'd say, probably going on 5 years now. And every time I had a question of where is it getting this number? Where in the heck is this number coming from? I would call them and I'd put in a ticket and I'd wait a couple days and I would get an answer back. Well, it must be coming from this OBS term or from this encounter. Okay, great. So when Alaska PCA approached Melody, who's our executive director, with this Azara platform with the Drive, we wanted to hop on this bandwagon. So we got on the bandwagon. I was a little hesitant at first because I'm like, oh gosh, if this just turns out like the one I'm using already, why do I have to learn something new? So we got our implementation date, and up came our Azara representative, and we sat there with these spreadsheets and going over our workflows and where things were being mapped to. And I just found it very exciting because they were making the data that I was getting true, and I was the one validating it with her. I was sitting right there next to her, and I was validating all this data, and my numbers, they were looking different after they turned it on. And so I believed in my data, I guess is what I'm trying to say. I did not believe in my data from that other platform. And one day I sat down and I actually compared the two, measure for measure. And they were off quite a bit, the other one, to what I had in Azara. And I actually believed Azara because I validated that data. I helped her map that data, and I believed it. So moving forward, a lot of my team uses the Azara platform. I will log in and I will show you some of the things we do. For a small CHC in Alaska, we have a very extensive quality program. We have peer review with not just providers, but with every department on the floor: nursing, lab, MAs, dental, behavioral health, and assistance. So monthly, we have peer reviews. The people love in the peer reviews that I give them their own little scorecards that I have created with certain measures that we're working on for the time period. Dr. Joan is one of my doctors, so every month I go sit with my providers and we do peer review. I give her a scorecard for that month. She looks through it. She gets excited on some things she says, what? I really have a person that is, I'm doing alcohol meds with? Oh, who is that person? And she'll look. I cannot dive down into my detailed data because I'm not allowed to for the presentation, but she'll take her scorecard and she'll go look and see who that person is. So when you present data to people, and like Dr. Joan, she likes to be held accountable for what she's doing. And she likes to know if she's doing good or if she's doing bad. And if she is faltering on some measures, how is she going to improve them? And we sit down and we talk about these things. And another thing we do with this is on our UDS measures. We actually run our UDS measures monthly and take them to meetings. And if we do not hit our targets that we have predicted for our SAC grant, which is our Service Area Competition Grant, that green line is what we predicted our target to be. That target is a 3-year target. So this is the target for the end of next year. But you just have to filter out your providers that are actually in the measure. And then it loads. And I have to tell you that my favorite function of Azara, I cannot show you because it's in the detail here. If you click on the detail list and you get your list of patients, which is going to be these patients that when you hover over the percentage is in the numerator and denominator. it's going to give you that list of patients. And I've never seen this in any other platform, but I can right-click on a patient in that detail list and say, investigate the measure. And right then and there in front of me, it pops up why they aren't in the numerator, or if they're in the numerator, why they aren't in the denominator. It tells me what exactly is missing from this patient that makes them not count for my UDS measures. And I absolutely love that part. It has been a very integral part for me, who sits here all the time and dives down into that detail for the UDS measures, to try to find out where are we going wrong and how can we improve our workflows. I have a lot of the team that use it, and a part of my team that uses it the most is my case management assistant. And they go through measures to get all of our, say, our Medicare annual wellness folks. We want to make sure that we are trying to capture Medicare annual wellness visits, and this is something we just started trying to achieve. And so we actually started a Medicare annual wellness procedure and program with our case managers at the beginning of the year. And then we got Azara, and I found this measure that told me who was due for a Medicare annual wellness visit. And that just made me happy as all get out, because then I went in and exported my detail list to Excel of all the patients I could reach out to and send them a letter stating what a Medicare annual wellness visit was, why they should have one, what it included, how personalized they are. And all of my case managed assistants on the team sit down and take this detailed list and start sending out letters, and then they chart that in the chart, and then they follow it up with a call. And we've started actually getting patients in our nurse schedules for Medicare annual wellness visits. So that was exciting to us. The other thing I do is we make registries. We're a very small clinic, but we have a lot of people with very chronic conditions because we are out very rural. So we create registries. We have a program called Living Well. Living Well is a program, it's a 6-week-long program where we have 2 people basically teach you how to manage your chronic disease. And we have a group of 6 to 10 people, patients, attend the group. And so we built a registry to find our patients with the chronic conditions, with multiple chronic conditions, to call and see if they would like to participate in the class. So we've done that. I've also made us a chronic case management registry of people that we can sign up for chronic case management, which we are just starting to do as well, which we are piloting Azara's care tool for right now. The other thing that I use Azara for a lot is every month I meet with our board of our clinic, and they're volunteers, and they all have to participate in a committee. And the ones that participate in the quality committee, they love measures and graphs, and they love to see pictures. So every month I pick measures that I think would interest them, and some they pick the month before and tell me that they would like to see. And I go in and I print them out for the quarter, because they only get the graphs every quarter. They get the information monthly, but I only print the graphs out every quarter. because it's a lot of work to get all this together for the board. But like this measure, our colorectal cancer screening, it's something we wanted to really, really, really truthfully do better on. And part of things we did was we look at these numbers when we run the measures, and our patients that we have up here are of populations that you kind of have to wrangle in sometimes. We do have the slide, we work on the slide. So we really, really wanted to try to get our numbers up. And I can tell you at the beginning of 2017, our baseline for colorectal cancer screening was 1%. And so over the year, we've tried to concentrate on workflows around colorectal cancer screening and tried to get our numbers up to at least our target that we predicted on our SAT grant. We had team members wearing pins when they were rooming patients saying, hey, if you're between the age of 50 and 75 years old, ask me about the gift I have for you. So that we could give them an IFOBT to take home. We were trying everything. The other day, I looked at our numbers and it went down. And so I went over to the clinical floor, sat down with the clinical team and said, are you guys handing the kits out anymore? We were trying to do our due diligence. We were trying to really move our measure up. And they said, well, we've been handing out the kits, we're just not getting them back. And I said, well, how do these kits come? Let me see one. And they brought me a kit and it came inside of an envelope. And I said, are you guys pre-postaging these envelopes before you give them to the patients so they can send this back in the mail and not have to put their own stamp on it? And they said, oh no, we didn't even think about that. And I said, well, are you really getting any back in the mail? And they said, no, lots of times the people will drop them off at the front desk. So I went to the post office and I bought a roll of stamps. And I had them stamp 100 envelopes. So now going forward, we're going to hand these 100 envelopes out and tally how many we get back and see if our number goes up. I don't know, I use the dashboards a lot too for my board. I can go in personally into the admin and I can add users. I can make cohorts. I can look at my mapping. That's stuff that I do, not everybody does. I can tell you a lot of my case management assistants tend to use their favorites a ton. When they create their own scorecards and things like that, they tally them to the favorites. We do not use the visit planning. We make our forms in Centricity. We actually are very proactive with our forms and we can make them to how we want them. So our visit planning huddle that we've created is extensive for how we use it. So we don't really use that. A lot of things I do use that they just came out with is this data health. In a prior application, I had said to Azara, hey, I had a data pollution section where I could go see and try to weed out wrong things that were put into the EHR, like a 2-year-old that has a status of married. Well, you know, their parent was filling out the forms and just thought of themselves and checkmark married. But that was the kind of stuff I could fix with that report. So they are coming out with these in the data health where I can look back in my week and say, okay, all of my BPs that were recorded, did they look normal? And if it did not, I could say, okay, there's 2 questionable BPs here. Let me dive down into the detail list. Let's see if this is a specific person doing this, if it's a workflow issue, and let's see if we can get it corrected. The other thing I like to use is, I don't know if you all, we're integrated behavioral health and we do a lot of OBOT programs, which is office-based opioid treatment groups. So a very big part of what Azara has done for us is we have their substance use module. And in that, I can sit down with Dr. Joan, who's our MAT and runs the program with our behavioral health provider, and I can tell them certain things that they want to know on who has opioid use disorder, how many people they have in the groups going on right now, how many people are compliant. So these are reports for the substance use that we actually use quite a bit with the providers that run groups and with the behavioral health providers that are in the groups as well. They like to see this data. It empowers them, it excites them. I've never had anything like it do this. I always tried to get them excited about stuff, and I always felt like I was telling them to check one more box so that I could get a number. And I always thought, good Lord, when they see me coming, they must hate to see me coming, because every time I come over to see them, it's about something we need to do, or one more box we need to check, or this or that. And when I started showing them these graphs and what I could put together for them and what measures were already in here that we could dive down into and create targets, I'll tell you, the team was really, really, really excited. So that's about all I have to say. I don't know if you guys have questions for me, or if you want me to show you any more reports. Use a lot of them.
Thanks a lot, Cricket. I appreciate it. So I'll just look to the room or anybody online to see if anybody has questions for Cricket.
I want to thank her for preparing this. I mean, she did a great job presenting that, and that actually showed more usability than Chris's presentation. And I think Chris does a great job. So Cricket, fantastic.
Kudos, Cricket.
Do what?
We just said kudos to you because the way that you demonstrated the Drives interface was showed a lot more usability and user friendliness than even Chris doing his tour of it. So
well, I wish that I could dive down into the detail, because that is where you get to the meat of what you're doing.
Yeah.
And I love Investigate Measure. I can't talk enough about that Investigate Measure.
April, go ahead.
Cricket, how long did it take you to get things mapped?
Okay, I can hardly hear you, April.
How long did it take you to get Centricity mapped to Drives?
Oh, okay. So that was not bad at all. Implementation of this product took us 5 days. Lori Lenz and I from Azara basically sat in a room for 5 days. During the work day, we took lunch. We went and chit-chatted with people sometimes. But we sat in the room for 5 days with her mapping and me validating, and then me changing things the way that workflows changed. And it really was not a bad process. And that's why I believe in what the data the integrity of my data, because I was the one validating it for her. And then we added the substance use module, and that actually only took me maybe 4 hours to do that whole module. So it's not bad.
Great. Thank you.
Thank you.
You're welcome.
Colette, any questions from you folks there?
Oh, and the one thing they did do for us when we did do the implementation and we did all the mapping and validating, we took our data back 2 years.
Okay.
So, yeah. So it just wasn't starting off with data that month. I could go 2 years back and run data.
That's great.
And get
yeah, that made it a lot more valuable, I'm sure. Any other questions for Cricket? Well, Cricket, I can't thank you enough for doing this. We really appreciate it. And I continue to just be so impressed and excited for how you guys are using it. I love it.
I'm excited too. I can't wait till we're done beta testing the care management tool. That thing is incredible.
Yeah, that's going to be, yeah, I'm looking forward to seeing that.
Okay, we'll see you ladies next week at the Data Hybrid Summit.
All right, awesome. We'll see you then, Cricket. Take care.
Okay. Have a good evening, everybody.
Thanks. Okay, so I think I'm able to go back. So yep, I'm back in the PowerPoint. I think I was just gonna finish up. Do folks need a break or anything? I think people have been just taking care of themselves. Hi.
Hi, at work. Yeah.
Awesome. Hi. No, that's all right. Thanks for coming. So we're okay to go forward. I think the rest of what we wanted to share was really just kind of the administration or the infrastructure part of the network. So I'll go through this as quickly as I can. Maybe.
Nancy,
Yes.
one thing I want to add to the folks that might be watching the recording later.
Yes.
Is that maybe not Cricket as much, but you both and Chris would be available for their questions as well as the ones that we're taking.
Oh, please. Yes. If anybody has any questions, no matter if you're here or you're not here in the room tonight or you're watching this recording, feel free to reach out to any of us. We are always happy to talk about this project. So I just wanted to show you this graphic. This is the Alaska Primary Care Association's graphic from several years ago. About 4 years ago, we realized that the trends nationally were that health centers really needed to know about what they were doing, where they stood, how well they were performing, who their patients were, and how healthy they were and why. And we realized we didn't have any of this data. We were a little bit worried because we thought everybody else was way far ahead of us. So we scrambled. We brought a couple of consultants up to help us to map out this roadmap for where we should go in the next several years. And then we just started. And so what we did was we have 4 phases here. The first phase was really us working together as health centers and getting used to working in partnership. We did that with an Office of Rural Health Policy grant with a couple of our health centers, and we started doing some shared servicing, and we ended up doing providing a credentialing service to some of our health centers in Alaska. From there, we really wanted to move into phase 2, which was really data analytics. And under data analytics, you can see the small print says HCCN funding, community health center contributions and user fees, grant funding, and APCA contributions. And in this phase, we got here just about the time when the HCCN funding was made available 3 years ago. And so we decided to go ahead and apply for the HCCN grant. This is a description of the network that we built in Alaska. And really, I have to confess that what we did is we got to know other networks across the country. And we became friends with those networks that were succeeding and that we thought HRSA was really pleased with. Because we thought to give us the most high likelihood of success, we might as well follow in the footsteps of folks that had tread that path before us. So we became really good friends with the Missouri Quality Improvement Network, or MOQUIN, and we decided to take some of their best characteristics of their network and build them into the Alaska one. So really what it is a quality improvement project with an IT tool. It is not an IT project. The abstract for the first 3 years looked like this. we decided we needed to start at the very beginning, and we needed to start with a basic assessment of where health centers were and where we were as a primary care association. The first 3 years was really spent on developing a very strong foundation of quality improvement technical assistance, and then securing that data analytics and data warehouse platform. And then we spent the rest of the first 3-year term in deploying that Drives platform. So that now 5 health centers are up and running, and we have another 6 or so in the queue. So now, just last week, the second round for us, the second round of health center controlled network funding was issued, and the grant is due in January. And where we are now is we would really like to invite Wyoming health centers to join the Alaska Quality Improvement Network so that we have a network that's bigger, somewhere between 50 and 20 health centers. We think there's strength in volume. There's really strength in sharing data across that large of a network, getting to know what other health centers like you or not like you are doing, and what has made those health centers successful, and how folks have learned from trial and error and learning from best practices. So it's really, this second year term for us is all about building out the capacity for health centers to understand their own data and to be ready to engage in value-based care and contracting. And so this proposed abstract contemplates Wyoming participation, if you guys are willing to join us in this project. So this is really why I am not a graphic designer or a graphic artist, because this is the best I can do to convey the concept of what this is. So each individual local community health center, as represented by small circles on the left-hand side, has your own EHR. You don't need to change your EHR because the data warehouse and analytics platform that we chose, Azara Drives, is EHR agnostic. And as we've just told you, Azara goes in and maps your particular EHR data to the data warehouse, to a common dictionary. Then there's the magic of that thunderbolt and the data analytics. And then what comes out the other side is what Cricket and Chris have shown you. And that is all of the data analytics that you can use for your own health center. We can aggregate health centers together and use the data analytics on a group of health centers or the entire network. And any which way, we can use that data for our own network, or we can share it with payers, either Medicaid or other carriers, who will likely be very eager to have that data. And then it feeds back into all of the health centers so that we get to become stronger. One of the requirements of the HCCN grant is a memorandum of agreement. And this list represents basic elements of the memorandum of agreement. It outlines roles and responsibilities both of the participating health center and PCA. And all of the health centers must sign this before we actually submit the grant application in January. Are there any questions about the MOA and what might be included in it? I think just a couple of things probably deserve mention, and that is that the network is governed by a steering committee that has representatives from each participating health center on it, each with one voice. There are business associate agreements that protect everybody and protect personally identifiable information, and EPHI. There's a participant investment and a commitment so that each participating health center really commits to having an operational point of contact, usually a champion that really is the one who trumpets the benefits of the program. Health centers can only be in one HCCN. And then there is a financial commitment somewhere between $14,000 and $16,000 a year. And if you decide to add a couple of other modules, optional modules, the annual commitment can get closer to $17,000 or $18,000. It's calculated based on the number of medical encounters that you have in your UDS. So this is just a graphic that everybody has seen a million times, and it's a reminder that as we go from cost-based to full capitation kind of payment arrangement, there is an increasing amount of risk that is taken on by a provider. And yes, there's an increasing amount of reward, but generally I can tell you right now that Alaska Health Centers are nowhere near taking on risk. We are at the almost very bottom of this slope, and we're right now fee for service. All of our health centers are just getting PPS. We are entertaining managed care coming into our state next year, and some health centers are talking about entering into PPS plus arrangements with the MCO, but none of them yet are taking on risk at all. But one reason is because we just don't know the data well enough. We don't know where we are. We don't know how much risk we could really take on. And so Azara Drives is just really empowering when it comes to thinking about the future and where we need to be in order to prepare to be in those kinds of arrangements. What's interesting about this latest round, this funding opportunity announcement that just came out last week for the Health Center Control Networks, it is that the purpose of the HCCN funding has changed dramatically over the last 3 rounds, where the first round was really about EHR adoption. The second round was more about meaningful use and participating in HIEs. This third round is, I'm going to read it to you, is to increase participating health centers' preparedness for participating in value-based care through enhancing the patient and provider experiences, advancing interoperability, and using data to enhance value. So that's where we are. AQUIN is, again, based on a HRSA-funded program that doesn't see an end at this point. The HCCN program as a whole was able to return their ROI calculation to HRSA very quickly, showing some very convincing data about the usefulness and the value of the HCCN project. So we don't foresee that this one is at any risk for termination anytime soon. The grants begin at the amount of $500,000 each year for a 3-year period. That number increases with each 5 health centers that you add to the network. I guess I did some really fancy stuff with this slide. Okay. So we did start with 10 health centers in Alaska. We're up to 12 because it's just been a really convincing project. Folks have been able to see the value of the direct training and technical assistance that the staff has been able to deliver, to tailor that training and technical assistance to the individual health centers to meet them where they're at and attack their first priorities. And then to be able to see Drives, that tool that can be modified and used by each health center exactly the way they want and focus on the kinds of data that they are most concerned about. It's just been a really powerful project. And so we have been able to attract some additional health centers into the initial 10. So like I said, this is the goals and activities where we've been the last 3 years. We'll slightly modify these so that we do address the purposes of this round, which are again to enhance the patient and provider experiences, advance interoperability, and use data to enhance value. So this is the same chart that you saw Chris to display and walk through that really talks about which team members from the health center need to be involved in the implementation of drives at the health center. And you can see that the network administrator or the IT person is really minimal, because that's not where the heart of this is. It is in the data analytics. It's in the informatics. It's not in the IT. It's in where the data lives and the manipulation of your data to get actionable data. That's what informatics is. I'm pointing at April because that's her role at the health center, yeah. It's being able to use all of that work that you do on your IT network and actually get good stuff out of it. So that is the last slide that we have in our formal presentation. And I think at this point we were hopeful that any questions that might still linger, you might be able to ask, and we could have a discussion about your EMRs and what your known issues are around data, and if you think this could be a powerful or useful project for you to engage in. And before we do that, I did want to back up, because sometimes I know health centers see this kind of a product and they're really excited, but the price tag can get in the way. So I will tell you that that was part of our deliberations about choosing our data warehouse and analytics platform. We wanted to make sure that it wasn't going to be so expensive that health centers couldn't afford it. Because if we went that direction, it wasn't going to help anybody. So this analytics platform, like I said, is based on your medical encounters as reported on your latest UDS. If you have, it's probably our health center that sees 15,000 clients a year. So their medical encounters are much higher than that, but that's the number of patients. They are right at the cusp of the minimum charge for health centers. So they're right at $14,000 to $16,000 a year. So, and I don't, how many patients do your health centers see here? What's average? Okay.
Yeah,
So you're going to be under. Okay. So the minimum number should apply, the minimum cost.
Yeah, I mean, you can do the calculations, but we kind of did look at that. That's what we came up with. The other thing that is important to know is if HRSA continues with their quality awards and doing this kind of activity where it is quality improvement, you should improve and get more awards.
Quality awards, right?
More quality awards. So we actually did take your UDS data and did a projection of all these. I don't think we've sent it yet, Jan, but we will, and you guys can use it to talk to your health centers about where, what that might look like now.
So if health centers are not yet submitting their UDS electronically, you can see that Drives will allow you to do that, and that will give you one of those awards right off the bat. And also this year, I believe HRSA changed it, so you have to submit your UDS electronically to be eligible for any of the quality awards. So that makes a project like this even more important. Also, your quality awards from HRSA have to be spent on quality improvement. So it's kind of natural to be able to spend them directly back into your subscription fees. The other piece of the data warehouse is, of course, the implementation cost. And we've been through quite a few of these so far. The base cost of the implementation is around $45,000. There are additional costs that go into that with additional optional modules, and then the travel costs for the Azara staff that actually go on site. And so far, we've been able to cover all of those costs for the health center. It would be our hope that we would continue to do that because, again, we do not want that to be a barrier to health centers being able to have access to this tool. So it will, we will be scratching out a budget in the next few days. And we know that we have space in our network for a handful of health centers. And so we will be eager to hear from folks soon, the sooner the better, so that we can make plans for what that budget looks like. And it will be our desire, and we will hope, and it will be our aim to be able to cover all of the implementation costs for health centers for the initial drugs implementation.
Patty, this is Colette. Sorry, you cut out a little bit. I just wanted to confirm that. So the implementation, if we were to say yes, we're going to do it. At the end of that, I caught that you guys are going to try to cover that for some health centers, but if that doesn't happen, it's a $45,000 give or take implementation fee, and then it's an additional $14,000 to $16,000 each year. Is that correct?
That is correct. That is correct. Okay. So right now we have 12 health centers in our network. So the funding goes like this. If you get 10, it's $500,000. If you get 15, you get $625,000. So if we can get to 15, if we can get 3 more health centers in our network, we'll get that additional bump, and then that will just about guarantee that we can cover the implementation costs for all of the health centers that will implement in the next 3-year term.
And did I catch that right? You're covering that through the grant dollars that you get for the HCCN from HRSA?
That's exactly right. Okay.
And then is there any additional costs to join the HCCN? I mean, that just basically covers the Azara part, but is there any additional costs as far as the HCCN participation, or is the HCCN participation really based solely around Azara?
So it's the additional cost to you would be time and energy, because in order for this project to be successful, we need the participating health centers to contribute to the steering committee, the direction of that group, and the strategy of this project. We are going to come to a point, because this data warehouse is going to become very rich in data, that we will need to make decisions about data governance, data use cases, and all of that is going to come to the steering committee. So there's no additional financial cost. And I would say, as far as what the network components are, Azara Drives is the most obvious and concrete. You can see it. But the other things that come along with the network are the really important training and technical assistance that you will get from both the Alaska and the Wyoming PCA staff that will help you to dig down into that data and really figure out how to make a difference in it, how to impact change and improvement. So can I financial cost? No.
Okay. And then just kind of a follow-up on that. As far as the HCCN, the network itself, obviously it sounds like it's pretty much the health centers are getting individualized benefit from the Azara stuff. And then really the benefit from the HCCN itself is the training and technical assistance from the 2 PCAs. So is that correct?
Yes, I would say that's correct. And then, where this could go in the future is really up to the health centers as far as, how far folks would want to take it in Alaska, because we're going to be welcoming in managed care next year. Some of the smaller health centers that are in the network now are really thinking about becoming a clinically integrated network and being able to band together in order to negotiate in a better position for contracts, especially with carriers and Medicaid actually. in doing that, because you can come together and negotiate better with more and more patients. So, but that's an aside from the network, but it's someplace that folks could look next.
Well, how does that look for Wyoming then, as far as that network goes? Just because, say, there's 3 or 4 of us that join, obviously there's a few more a lot more Alaska health centers. And then, so I just am looking at that map. So is there some barriers to why some of those other health centers in Alaska haven't joined up with this project?
Yes, actually there is. The Tribal Health Consortium in Alaska decided a few years ago to use a single EHR Cerner and to be able to vertically integrate a number of tribal organizations into this one instance of EHR. So not all of the tribal organizations actually joined that Cerner domain, but those that did are not able to join our network at this time because of the inability to actually tap into that data that they've got right now. We hope at some point that barrier will be broken down, but it isn't right now. But we have been able to get 2 tribal organizations into our network. And so it's not that it's a tribal, non-tribal thing. It has to do with that Cerner domain. So we're hoping at some point that barrier will go away. And as far as the clinically integrated network, that would be something distinct from the HCCN. So not every health center that is in the HCCN would have to go into a clinically integrated network. It would be an additional opportunity that would be offered at some point in the future.
I want to talk a little bit about the support staff that we have. Like Nellie.
You know what? I would like to, I'm going to switch places with you though, because I think the microphone is in the laptop.
So you want me to talk?
Yeah.
So at the PCA, one of our strengths has been for the last few years that we've developed our quality improvement, technical assistance, and training, and we have a really rigorous program. And so those resources, to the extent that they're covered under the HCCN, would be available to you. Plus, we're working with the Wyoming PCA to we're partnering and sharing each other's best practices so that we can learn from each other and take new information to our health centers. But also on our staff, we have, what's her title?
Clinical applications.
Clinical applications coordinator, and she's she's not quite there yet, but she's getting there pretty fast, the Azara super user on our staff. So when you first implement, you have access to Azara pretty regularly, but then when that sort of, as you get better, you don't need them as much, and that kind of wanes. And so we're actually having our staff learn from Azara so they can take that place and provide those services. And so that particular, that we have one staff person right now doing that, and she goes on all the implementation visits. Anything else?
So I think the other thing that we'll continue to do, we started doing this year. We have a number of quality improvement TA opportunities, and they happen on a regular basis. We have something happening every month. So every other month, on alternating months, there will be kind of an academy, and that's more like a scholastic kind of opportunity where there's really some instruction or teaching that occurs around an element of QI. And then on alternating months from that, there's a data deep dive where we all get on a video teleconference together, and the staff help everybody dive down into their own data to really analyze the numerators, denominators, what went into a certain measure, figure out what's going to make a difference and an impact that measure. So those happen on every other month. So Academy, Data Deep Dive, Academy Deep Dive. And then twice a year, we do population health and data-driven data summits. And so those are a gathering of people, and for, it can be multi-days. The first one we had in the spring was 3 days, where people brought their own data, whether it was UDS, their EHR, or drives, whatever people have. And again, we do really deep analysis on folks' own data. We do run charts and workflow analysis. We do exercises around all of that data and ways to impact change in the clinics. And so that happens twice a year. Our semi-annual data summit for the fall, it happens on this coming Monday, and it's actually a hybrid summit. So some people will be there in person, and some people will be joining remotely using the Zoom platform. So those QI opportunities happen on a monthly basis.
This is great. I have a quick question. So say more than, you said we need 3, all 6 centers in one join, can they?
Yes, so that's a good question. So Grace asked that I said that we could easily accommodate 3 more. What if 6 Wyoming centers wanted to join the network? Yes, I think we can accommodate that. We also think that we have another couple, a small handful of health centers in Alaska that might want to join the network as well. And so that next level would be from 15 to 20. We could almost get there, and that's where we'd like to head, actually, is to 20. If we ended up 21, if we ended up someplace in between, then we just have to, again, I think it just comes down to the budgeting and figuring out how we budget out those funds over the 3-year period so that we could support the health centers the best that we could, knowing full well that one of the biggest issues for this project for health centers to be part of it is the not only the implementation costs, but the ongoing costs, and to do what we could to really help folks with those, and the implementation costs being, I think, the biggest barrier. Right, good question. So Grace asked about sites versus health centers and how implementation works. It is per health center organization, so that price is not per site, and the implementation happens at one site, whatever the main or headquarters site is. That's where the implementation happens.
But they implement across all the sites.
Right, but it's implemented through the EHR, which hopefully is used the same at each of the sites. Right? Yeah. Also, I just wanted to mention too, I know there are a variety of EHRs that are being used in Wyoming. That's the same in Alaska. I think there are 7 or 8 that we have in the network. Azara has worked with a multitude of EHRs, and we haven't found one yet that they have not already been involved in mapping. But there's no real economies of scale with that, because one health center might be using NextGen in this way with these workflows, and another health center might have NextGen also, but they use it in slightly different way. So each health center, again, is mapped uniquely, knowing that they generally use their EHRs in a unique way.
Well, I think that's a really important point. in terms of anybody feeling like, you know, it's just a shoe-in, you know, that they're not gonna get individual care on their own.
Oh, no.
Oh, yeah.
Yeah.
No, it's everything really has to be individualized. There's clear recognition that every health center is unique, and that you guys know the best way to run your health centers. And so there's not no one will come in telling you how to do it. I think but on the other hand, there is that expertise that is available, so that if you're interested in diving down into your workflows and uncovering some things that might be done differently to improve things in the health center, folks are more than happy to get on that diving board with you and go down and really investigate what's going on.
This is right. There's one thing I think this talked about a little bit in terms of so there's information available. So
Yes.
I see applications, you know, both of these lessons for this tonight have reviewed, and I see that I look at that differently and how to think about that. So I think it would be important to really address that that's acceptable and it's not, I won't say it's not too difficult, but it's pretty bad.
Yes, so the point was that there is customization available within Drives. I think it's important to note that Drives comes fully functional with a number of auto-populated reports, you know, that you can just choose your parameters and it runs. But there's great functionality in customizing things, like customizing panels and registries and scorecards and all kinds of things. And it is not too difficult to learn how to do that. And the Azara staff actually spend quite a bit of time with clinic staff showing them how to do that and build their own scorecards and making sure that they know how to customize the tool. Because again, if it's not what you need, you're not going to use it, right? And then it's just a tool that sits on the shelf, and that's not helpful for anybody. So they really do spend the time to make sure that health centers understand how to customize it. And then if you are done with your time with Azara, if that standard onboarding time is over and you still have questions or thought of something new to do with Drives, Nellie in our shop is going to be our super user and already is super excited about it and has a lot of knowledge already in helping folks understand how to use it differently. And then coming back to those data summits and the monthly QI opportunities, we routinely engage the Azara staff to help us with those. And so they are never far, they're on speed dial for us as well. So we have them on contract, not to help, well, to help us definitely, but to help us to help the health centers. And so they are regularly on those phone calls on a monthly basis, and they are regularly at our data summits because we know that they are continually enhancing Drives, and we want them to show us the latest, greatest, the tips, the tricks, you know, and how to navigate around that system. So we have ongoing access to them as well and bring that to the health centers.
Last chance for questions.
Last chance for questions.
I just wanted to say that I think when Cricket did her demo, you saw how she didn't use it probably the same way that you might use it, right? So every health center figures out what works best for them. And I just want to say that when Chris said twice tonight that we meet health centers where they're at, he totally stole that from us. Because we say that all the time. He totally stole that.
So, well, thank you guys for having us. Thank you for letting us crash your parties. Thank you for hanging out with us this evening. Again, like you said, like you probably noticed, we are very excited about this. We think that this project holds a lot of potential for health centers and really puts power and control in your laps, and we want to help you get it.
Well, I'm coming closer to the speaker because more than anything else, I mean, the fact that these ladies flew in from Alaska to be with us, to come to a UDS training, which they do all the time themselves, is a pretty big deal. So I really have to throw the thanks back to both of you for coming and also for answering the questions not only that come up as we go along, but also when we put this out to be reviewed by our other health centers. And what we'll probably do is time limit the viewing for it so that we can make sure that they understand that the clock is ticking, and so we'll do that. But I know that you guys will do a wonderful job in answering questions going forward, and I can't thank you enough for coming down.
Yeah.
So
Thank you very much.
thank
We
you.
love Wyoming. Good night, everybody.
Thank you.
Oh, I forgot Tara was on.
Hi, Tara.
She's with
Hi. Bye.
Hi, guys.
So what's your role at the public policy? Okay.
Want me to plug in?